Good morning, students. Welcome to today's lecture. Today we will be beginning with a new topic, miscellaneous disorders of oral cavity. This topic is divided into two parts, and today we will be covering part 1 of this topic. So for the learning outcomes, at the end of the lecture, you will be able to outline the rationale of unclassified lesions of the oral cavity and list out at least 5 examples. You will be able to describe in detail the clinico-pathological concept of geographic tongue and orofacial granulomatosis. You will also be able to clinically identify common entities like Fordyce's granules, sublingual varices, and lingual tonsil, and differentiate them from other lesions. Before we understand the concept of this chapter, let us look at this picture. I'm sure everyone is familiar with this board game, that is the jigsaw puzzle. This game involves positioning of each segments of a picture in the right place so as to reveal the actual picture. It should be noted that when a particular piece of the puzzle is placed in its accurate position, only then it will reveal the picture. Positioning the pieces in a random manner will not reveal the picture. So, applying this concept to our topic, we have studied about a number of lesions under oral pathologies. These lesions share some common similarities, for example, similarities in terms of its clinical behavior, clinical features, radiographic features. Some lesions may have a common or similar pathogenesis. Some lesions may have a common outcome. So based on these various categories, lesions have been categorized as cysts of jaws and oral tissues, hyperplastic, neoplastic and related disorders of oral mucosa, keratosis and related disorders of oral mucosa, oral epithelial tumors, infections of oral mucosa, odontogenic tumors, diseases of salivary gland, and so on. However, there are certain lesions which would be difficult to be placed under these categories. So, for such lesions, we need to have a separate category. And this is what we refer to as miscellaneous disorders of the oral cavity. So, lesions which cannot be classified as keratotic or cystic or odontogenic or a salivary gland lesion, for example, is categorized as a miscellaneous lesion. We'll be discussing a number of miscellaneous lesions in this chapter. In the next chapter, we will also be discussing about various forms of pigmentations of the oral mucosa. Before we begin with the specific topics, let us understand some terminologies which are related to today's chapter. Chronic granulomatous disease is an inherited primary immunodeficiency disease which increases the body's susceptibility to infections caused by certain bacteria and fungi. This description of chronic granulomatous disease has been given by the American Academy of Allergy, Asthma and Immunology. Granulomatous inflammation is a distinctive form of chronic inflammation produced in response to various infections, which could be autoimmune, toxic, allergic and neoplastic condition. Granuloma, on the other hand, is defined as a focal, chronic inflammatory tissue response composed mostly of macrophages and their derivatives, that is, the epithelioid cells, which is evoked by persistent, poorly degradable substances. It is suggested that the term granuloma is understood thoroughly so as to understand the various pathologies which will be discussed. In short, granuloma is nothing but a histological term which describes a focal collection of macrophages in the tissue. It should be remembered that macrophages are tissue scavengers and basically deal with the removal of debris from within the connective tissue. So this debris can be any infectious material or other poorly degraded substances such as a foreign body. So whenever such an instance happens, there might be a chance of granuloma formation. As I already mentioned that granuloma is a histological term. To identify granuloma in a piece of tissue, we should be able to identify the following features. As I mentioned, granuloma is a focal collection of macrophages. However, in most of the cases, macrophages do not appear as few scattered cells in the tissue. In response to a poorly degradable substance, the number of macrophages will increase and they will show certain alteration within their structure, such that numerous macrophages will be present adjacent to each other within the connective tissue. Because of this appearance, they resemble the cells of the epithelium and have been referred to as epithelioid cells. Also, some macrophages tend to fuse to each other and result in what we know as a multinucleated giant cell. Certain multinucleated giant cells will have a pattern of arrangement of nuclei. For example, the Langhans giant cell, whereas others will show a haphazard arrangement of nuclei. So, a granuloma may show any form of multinucleated giant cell. In addition, we can also appreciate a cell-mediated immune response in the periphery. There will be a dense aggregate of lymphoid cells. Finally, necrosis and fibrosis may or may not be seen within the connective tissue. Some granulomas will show a central area of necrosis. For example, tubercular granuloma. You have already studied this topic and it characteristically shows the presence of caseous necrosis in the center. Some granulomas will not show any necrosis. The topics which we are going to discuss today will show such features. Additionally, increased fibrous proliferation can be seen in the periphery of this lesion. So, a number of lesions in the oral cavity will show granuloma formation. A term orofacial granulomatosis has been used to denote such lesions. It should be understood here that orofacial granulomatosis is not a disease entity as such, but a term used to describe the clinico-pathological manifestations of a variety of disorders. Orofacial granulomatosis most commonly presents with clinically as recurrent or persistent enlargement of the lips or the cheeks. There is a diffuse enlargement of the lips in such lesion. Histologically, non-caseating granuloma is the hallmark of orofacial granulomatosis. Such lesions may or may not show multinucleated giant cells. Orofacial granulomatosis can occur at any age group. The pathogenesis of some is unclear. As discussed in the previous slide, Orofacial granulomatosis is not a disease entity as such, but a common manifestation of a variety of disorders. So, different pathologies can present as orofacial granulomatosis, and this include Crohn's disease, sarcoidosis, foreign body reactions or foreign body infections, Melkersson-Rosenthal syndrome, a part of which is also known as cheilitis granulomatosa, allergic reaction to topical allergens, or some lesions could be idiopathic in nature. As discussed, presence of non-caseating granuloma is a feature of orofacial granulomatosis. This should be differentiated from other commonly occurring granuloma, that is the tubercular granuloma, which shows a central area of caseous necrosis. If you compare the two histopathological pictures here, you can appreciate that here there is a focal collection of epithelioid macrophages only, which is surrounded by a dense aggregate of lymphoid cells. However, the tubercular granuloma here shows a cheese-like central area of necrosis, which are further surrounded by epithelioid cells and giant cells, which is further surrounded by lymphoid aggregates in the periphery. So this point should be remembered so as to differentiate these non-caseating granulomas from the tubercular granuloma. So among all the orofacial granulomatosis, Crohn's disease is known to be the common manifestation. Crohn's disease is a chronic granulomatous disease and primarily occurs in the gastrointestinal tract, commonly at the terminal ileum. Crohn's disease is said to arise as a cell-mediated immune response secondary to exogenous or endogenous bacteria. This disease runs a chronic course and is followed by periods of quiescence and episodes of varying severity and duration. Mucosal ulcerations can occur in any part of the GI tract. Lesions being in the oral cavity are also seen. Other general features associated with Crohn's disease include abdominal pain, diarrhea, and weight loss. When oral features are seen in relation to this disease, we would generally see the most common feature, that is the presence of diffuse swelling of the lips and cheek. Remember that this feature is the most prominent feature seen in any orofacial granulomatosis. In relation to the buccal mucosa, we can appreciate a edematous and hyperplastic thickening. This can be seen in the buccal mucosa or the labial mucosa. This thickening is also added by the presence of fissures in between, so as to reveal what we refer to as the cobblestone appearance. This is the actual image of the cobblestone roads, which shows a resemblance to this lesion, and hence the term cobblestone appearance. Crohn's disease also reveals a number of polypoid tag-like lesions, which are generally present as deep folds of mucosa, often involved in the sulci. Here you can appreciate a small tag-like lesion in the vestibular sulcus. It should be remembered that such lesions may mimic the hyperplastic lesions which generally occur in relation to the dentures. Additionally, we may also see aphthous-like ulcers or linear fissure-like ulcers. Since Crohn's disease is a lesion of the GI tract, there will be retarded uptake of vitamins and other essential minerals from the diet. So, glossitis is a feature which occurs secondary to the deficiency of vitamin B12, iron, and folic acid as seen in Crohn's disease. If a biopsy is taken from a lesion or from the oral cavity, it will reveal the presence of non-caseating, poorly formed granulomas along with few giant cells. In addition, we will also see dense infiltration of lymphocytes and plasma cells, fibrosis, lymphedema and dilated lymphatics. As described already, non-caseating poorly formed granuloma is the most important feature of this disease. This granuloma is devoid of any necrosis and shows only focal aggregates of epithelioid macrophages along with multinucleated giant cells. For the final diagnosis, presence of GI lesion is mandatory. A lesion can be diagnosed as a Crohn's disease only when there is presence of intestinal lesions. This is an image of a endoscopic evaluation which reveals mucosal thickenings in the GI tract. Moving on to the next lesion which presents as a granulomatous disease, sarcoidosis. It is a multi-system chronic granulomatous disorder, generally affecting the young adults. A characteristic feature of sarcoidosis is the presence of enlargement of hilar lymph nodes, such that there is bilateral hilar lymphadenopathy. This disease involves the pulmonary organs such that it results in infiltration. Additionally, skin or eye lesions may also be seen, such that it causes dry eyes, blurry vision, rashes, lupus-like lesions on the skin. Orally, the manifestations are generally uncommon. However, it presents as submucosal, painless red nodules covered by normal mucosa or a erythematous mucosa. The gingiva may reveal hyperplastic changes. The features are similar to orofacial granulomatosis. Sarcoidosis may also reveal the involvement of the salivary glands. Here you can see the presence of submucosal painless nodules covered by erythematous areas on the buccal mucosa. Another important oral manifestation associated with sarcoidosis is the presence of a syndrome, what we refer to as Heerfordt's syndrome. Sometimes the term uveitis fever is also used to depict this syndrome. This syndrome includes the presence of uveitis, parotitis, and facial nerve paralysis. Incisional biopsy of cases of sarcoidosis will reveal small granulomas. These are generally non-caseating in nature as for all the orofacial granulomatosis, showing epithelioid macrophages and Langhans giant cells. Additional investigating findings in sarcoidosis will reveal a raised erythrocyte sedimentation rate, increased serum angiotensin converting enzyme, hypercalciuria. A clinical test used to identify sarcoidosis, also known as the Quine-Silsbach skin test, involves the suspension of granulomatous splenic tissue to be injected into the skin of a patient, a suspected patient. If there is development of non-caseating granulomas within 4 to 6 weeks, it suggests of a positive reaction. Treatment of sarcoidosis includes systemic corticosteroid therapy. Another lesion which can also be termed as a orofacial granulomatosis is what we refer to as Wegener's granulomatosis. This is an aggressive lesion, a systemic disease which causes necrotizing destructive granulomatous inflammation, principally of the respiratory tract. This lesion shows generalized necrotizing vasculitis. That means the blood vessels are affected. Additionally, features such as intractable rhinitis, sinusitis, cough and hemoptysis are also seen. The pathogenesis of Wegener's granulomatosis basically includes an immune-mediated vascular injury. That means the blood vessels are affected as a result of autoantibodies. The autoantibodies identified in this pathology has been referred to as the anti-neutrophil cytoplasmic antibody type C. In short, as referred to as the CANCA. Presence of these antibodies have also been found to be used as a diagnostic tool to confirm the diagnosis. Oral manifestations in case of Wegener's granulomatosis is seen in nearly 15% of the cases. A typical pathognomonic feature of Wegener's granulomatosis is the presence of what we refer to as strawberry gingivitis. There is hyperplastic increase in the gingival tissue with heavily inflamed granular exophytic lesions. The surface of the gingiva resembles the outer peel of the strawberry, and hence it is referred to as strawberry gingivitis. Additionally, there will be diffused ulcerative stomatitis, that means ulcerative lesions of other part of the oral mucosa, mobility of teeth, non-healing of extraction sockets. A biopsy tissue on histopathological examination will reveal granulation tissue with mixed inflammatory cell infiltrate. Numerous giant cells with areas of necrosis may be seen. This necrosis is seen in the involved blood vessels and seen as fibrinoid necrosis and proliferation of the intima of such vessels. Moving to the next, orofacial granulomatosis is what we refer to as the Melkersson-Rosenthal syndrome. It is a rare neuromucocutaneous disease and shows the classical triad of orofacial swelling, fissured tongue and facial paralysis. A minor form of this syndrome, which presents only as the swelling of the lips, is referred to as cheilitis granulomatosa or Miescher-Melkersson-Rosenthal. So that was all about the various forms of lesions which presents as orofacial granulomatosis. Now we'll discuss some other lesions which have been categorized as miscellaneous disorders. The most common other common associated lesion is referred to as the Fordyce's granules. This is not a lesion as such and seen as a physiological finding wherein it reveals slightly raised yellow bodies beneath the surface of mucosa. However, in some instances, these yellowish bodies are confluent, resulting in the appearance of a plaque. The term Fordyce's granules or Fordyce's spot has been used to refer to this lesion. This lesion is commonly seen in the upper lip, the cheek, and the anterior facial pillar. Rarely it is observed in the lower lip. This lesion is not actually a pathology and a normal physiological finding. So there are no significant pathological changes associated. What makes it as a normal physiological finding is based upon the histological examination of a tissue which is biopsied for Fordyce's granules. It is noted that the lesion shows nothing but the presence of sebaceous glands within the connective tissue. It should be remembered that the oral mucosa receives its lubrication from the presence of minor salivary glands within the tissue, whereas the skin shows the presence of sebaceous glands in the dermis. So sebaceous glands are a normal component of the skin epithelium, whereas salivary glands the normal component of the oral mucosa. However, in some cases we may also find the presence of sebaceous glands within the oral mucosa, and this is what leads to the presence of yellowish plaque-like areas and referred to as Fordyce's granules. There is no associated significant pathology with this condition. In some elder individuals, we may also see such bluish varicosities generally on the ventral aspect of the tongue. These are referred to as sublingual varices and are generally a feature associated with aging. There is no symptom or other associated findings associated with this condition. Hence, no clinical significance is seen. Another pathology termed as a miscellaneous disorder of oral cavity is what we refer to as the geographic tongue. Other terms used in relation to this lesion is benign migratory glossitis. This pathology presents as irregular, partially depapillated red areas on the anterior two-thirds of the tongue. These depapillated areas will generally show loss of filiform papillae, such that the mucosa appears reddish. However, the fungiform papillae are not lost and are seen as shiny dark red prominences, generally seen on the anterior tip of the tongue. The atrophied mucosa of the lesion, area of the lesion, will generally show a thin white line-like margin or a band-like margin on the periphery. Sometimes this pathology may also show the presence of fissuring on the tongue. The most characteristic feature of this lesion is that such areas of atrophy generally heal and again reappear in a different lesion at a different time. And that is why the term benign migratory glossitis is used. So that it represents or it resembles the map of the world, and hence benign migratory glossitis. This lesion is generally symptomless. However, some irritation may be associated when consumption of spicy food is done. The prevalence of geographic tongue includes 1% of the population. Such patients will generally have a positive family history. That means someone in the family would also be showing such lesions. Geographic tongue are commonly associated in patients who are suffering from psoriasis. That is an exfoliative disorder of the skin. Similar atrophic areas like that seen in the tongue may also be seen in other parts of the oral cavity, that is the buccal mucosa or the labial mucosa, wherein a small localized area of atrophy is seen, which would heal and move on to a next new area on the buccal mucosa or the lip. Because of the similarity in features to that of the tongue, the term Erythema migrans or migratory stomatitis is used. So here also a lesion will be there, which is erythematous in nature and surrounded by a white thin line. Once it heals, it would form in a new area. When a tissue from the geographic tongue is biopsied and studied under the microscope, it will reveal the presence of acanthotic epithelium. That means the number of cells in the spinous cell layer increases. Also, there will be neutrophil leukocyte infiltration within the epithelial cell layers. So, this concludes the discussion for today's topic. A link for this lecture will be posted on the discussion board that will be created on the Google Classroom. The link for the discussion board will be shared in the e-portal. Students are requested to listen to this lecture carefully, read the topics from the textbook, understand each topics, and post on the discussion board regarding any doubts or comments. So, we are still in the recovery phase of the COVID-19 pandemic. Things have relaxed nowadays, things are looking better, but I suggest or I request that we stay at home and stay away from any sources of infection as much as possible. Until then, study well, stay at home, stay safe. Thank you.